So I'm just putting it in the cloud for Brian, who said he couldn't make it. So everyone say, hi, Brian. Hi, Brian. Okay, so back to where we were. So they issued this report essentially identifying that it was systems that were allowing this to happen with people, but that also recognized that humans are capable of overdoing this. Seeing all my complete care friends. So what we ended up doing after this report came out was we went back into our systems and we started looking at our data. What do we have? What is present? What do we know? What could we know better? Where are things hidden? Where are things not collected at all? And we entered this major national conversation trying to figure out how do we improve this system. So then in 2001, they came out with a report called Crossing the Quality Chasm. And for anyone who knows what a chasm is, it's like huge, right? It's like the oh God, now it's blocking my mind. Grand Canyon, right? It's so big that you're not just gonna walk across this thing, right? It's actually gonna take quite an effort to get over it. And this is what they said was the gap between where we were and where we needed to be. So it wasn't that like this was gonna happen overnight. To get from here to here was gonna take a long time. So when you look at this, this report was issued in 2001. We are now in 2018, which means we are arguably 15 plus years into transformation, and it is still happening. That's what I mean by a transformation. This is not change. This is bigger than that, and it takes longer and it's more complex. When they issued this report, one of the other things that they came out with was sort of a guidance on where we needed to improve things. So if we were going to change this system, what areas could we look at to make this better? And they came up with 6 areas. First and foremost, the area of safety. Are all of the things that we're doing safe? And if they are not safe, why are we doing them? And recognizing that there are potential gaps in our risk management systems where maybe people were doing unsafe things because the system allowed them to do unsafe things. So how could we realign the system to identify those potential errors and prevent them from happening? Another was looking at the area of effectiveness. Are all of the things we're doing effective anymore? Or have we continued to do things that are not helping us? For example, we no longer need to collect routine CD4 counts on durably suppressed patients who've been in care for a long time, and yet we're still doing it. That costs money. And that's money out of our pocket as the taxpayer, right? So whether it comes from Medicaid or through the Ryan White program, you and I are paying to have those tests run that do not need to be run. That means we're doing things that are not effective because they're not telling us anything. Another area of improvement we identified was patient-centered, really looking at our system-centered processes and determining whether they're patient-centered. A really great example of this is in the system, we talk about retention all the time. Are patients retained? That's a system word. I am not retained. I do not want to be retained. And in fact, if you try to retain me and put me in any box like that, I will most likely choose not to be retained because I feel like they're trying to control me. But if you talk about engagement, am I engaged in my care? Well, that's a different question. I may come to my medical visits, which means I have retention, but if you talk about it in terms of engagement, patients are more likely to respond because I'm not looking to be kept by anyone. Another area that we thought about was timeliness. Why are people waiting 90 days when we know what they have needs to be seen in 24 hours? I think that was another big, huge error. It's like, oh, I have stage 4 cancer. Oh, awesome, we'll get right to that in March. It's like, well, I'm sorry, what am I gonna do till March? Am I just gonna sit in my head wondering if I'm dying? Am I selling my life insurance policy? Do I need to say goodbye to my kids? Like, I don't know what's happening. And so that really brought up questions of, is our system addressing people's needs in a timely manner? And if not, what are the outcomes of doing things so late? What happens to people when we make them wait? And I think if you look, especially in behavioral health, we know what happens when people wait. They don't go. Like, that's the end of it, right? We make the referral and it's finished, especially if you say, oh, awesome, the psychiatrist will see you in 3 months. Please follow up with your visit. Well, great, I feel like shit now. What do I do until then? So we had a lot of conversations about access. Another one had to do with efficiency. This would be, if I know that I have a patient that needs to have their blood drawn, why the hell do I not just draw their blood in the clinic where they're seen? That seems pretty efficient to me, especially when people are not making their blood draws. So there was this question of, could we do things more efficiently? Could we locate things together that would mean people would be more likely to achieve the outcome? So that's where you hear a lot of talk about integration, right? Which is, how do we take all of these systems that were doing all of the same things and integrate them and inform everyone of the activity so that I'm not doing the same thing 10 times, because that's what a lot of people were doing. And then lastly, and this is the area where I think we're doing a lot of work now, health equity, and ensuring that the services that we were providing were yielding equitable outcomes for everyone. And I want to make sure everybody has a clear sense of what I mean by health equity versus health equality. We are not seeking health equality. I do not want everyone to get equal services, because everyone is not equal. Everyone does not have the same care needs. Some people are sicker. Some people have more complex needs. Some people do not have social service support at home. It will cost us more money to provide care to get them to the outcome that another patient, we may not have to provide any extra additional support. And that's okay. And I don't want to begrudge spending that extra money, because that's what I mean about health equity. It means that everyone gets the same outcome. It doesn't mean that everyone gets the same amount of money. Does that make sense to everybody? We're all clear on that? Cool. So when they looked down then and said 10 rules for redesign, so if we want to redo this system, what could we look at? And they said, 1, care should be based on continuous healing relationships. I should have a care team that I'm engaged with, one that I stay with, and the ability to build a relationship with the people who are going to be caring for me in my lifetime. 2, that my care is customized according to my needs and values, so that we're having conversations with patients around their values of their care. One of the great conversations I heard one time was a physician explaining that when a patient said, should I do this treatment? And they said, unfortunately, that's not a question for me. That's a question you ask your family and friends, because that's based on your values. I will tell you about the treatment, and I will tell you what the potential outcomes are, and I can answer any question you want about that. But the choice is yours. And the only way we get to making that informed choice is by asking people about their needs and their values, which was not a conversation that was generally happening. We also wanted to make sure that the patient was the source of control. Gone are the days where we get bills from services and people we never saw. I'm in charge of my care. If I wasn't there, it didn't happen. And if you're going to bill me for a radiology screen, that's great, as long as I have the ability to also talk to that radiologist. Because if they're part of my care team, then I should have the right to ask them, when did they read my radiology, screen? And were they engaged in my care? And will they always be the person doing this? So it's really making sure that the care team is consistent and that the patient has access and control over what happens. Also, that knowledge is shared and information flows freely. Right now, we have a lot of systems that like to hold on to their data because they think it's theirs. It's not theirs, it's mine, because I'm the patient, and it should follow me wherever I go. And if my system of care needs my data to flow, then the provider needs to figure out how to make that happen. Decision-making should be evidence-based. Now that we do have information available at our fingertips, I think it's really important that we recognize in the redesign that we should start with what works, and not what we think works, but what we know works. I'm a huge fan of adaptations and adopting materials to your environment, but that is different than just sitting around and pulling something out of the sky that you brainstormed and trying to make it work. Always start with what other people have done and learn from that. That's good science, and medicine is a science, and I think it's important that everybody keep your science hat on when you're thinking about this stuff. 6, safety is a system priority. We wanted to make sure that no matter what, at the end of the day, we're being safe. Transparency was necessary. You don't get to kill my mom and then everybody in the hospital knows that that happened except for me. That is not fair. When people make mistakes, the rest of us have to know about them. Now, I'm all for peer-based discussion and root cause and understanding what happened and recognizing that medicine is a practice, not a perfect. And so there are mistakes, but when that happens in the system, we have a right to know that because that's our care, and it shouldn't be hidden from us. And also, our data should not be hidden from us. If a clinician does not want me to see their progress notes, then maybe they wrote something about me that they shouldn't have written. So when you talk about people's access to their information, we also have to have these conversations around how do we make this information accessible not only to the clinicians, but to the patients as well. We also want to move to a predictive model where we anticipate people's needs rather than waiting for people to get sick and come in and get care. We currently have a reactive system that sort of waits for illness, which is why people say we have a sick care model instead of a healthcare model. We also want to make sure that anything we're doing that is not valuable, that's waste, or stuff that we could do without, that we identify that in the system and we get rid of it. And then lastly, that all of our clinicians and our care teams are cooperating. There's this great myth about all doctors and their turf war and all this fighting, and no, I'm in charge of the patient, no, you're in charge of the patient. I don't care who's in charge. It doesn't really matter to me. But what does matter to me is that whoever is in charge is cooperating with everybody else that's providing care to me. I think that I, as the patient, should be able to decide who's in charge. It should be the clinician or the provider that I choose to coordinate my care. But it really should make sure that everyone on my team gets along. And if they can't work together and they can't get along, then that's when the transparency has to come in, and we have to talk about whether my care team is functional. At the end of the day, the Institute for Healthcare Improvement, which is one of the biggest thought leaders around how healthcare improvement takes place, they identified what they called the triple aim. And this was, if we took all of our efforts to improve the healthcare system and framed them around 3 goals, they said that first and foremost, we should improve the quality of care that we provide. 2, we should enhance patient experience. And 3, we should lower the total cost of healthcare in this country. So we want better outcomes, a better experience that costs less. But then we started changing our system based on these 3 goals, and then what happened is we stressed everybody out. And all of a sudden, all the doctors and nurses and care team people started jumping ship and quitting because we didn't think about them. And we thought a lot about patient satisfaction, but we didn't think a lot about clinician satisfaction. So we, in 2014, they actually revised the triple aim to the quadruple aim and said that it's about improving outcomes, improving experience, lowering costs, and bringing joy back to clinician practice. Making sure that the people who are working in our system are finding meaning in the work that they do. Because we had made the environment so chaotic that everybody hated working where they were working and everybody left medicine. So we realized that we needed to address that because we didn't want to burn everyone out in the process of improvement. So the question is, how do we achieve this, right? So we've got all these great frameworks, these great ideas, and then how do we move a whole country from one place to the next? And this was the big question in front of people. And one of the main ideas that came out, and the example that we're going to use for today, is called the patient-centered medical home. Has anyone heard of this, PCMH, or the patient-centered medical home? If so, can you type in the chat room or say out loud on the phone, what do you know about PCMH, if you know anything? So I see Sonia says no. How about our complete care folks? You guys know anything about patient-centered medical homes? Other than you are one?
I do, because I've been working for Complete Care for what, 5 years now?
Oh, nice. So tell us about patient-centered medical homes, Brandy. What do you remember? Because you probably saw Complete Care build theirs, huh?
Yes. But it's basically just the patient being with us, and we're like for basically every little visit, and we're basically literally their home where they would go for everything.
Yes. Like, think literal home.
Yes.
Like, all the things that happen at home, when you brush your teeth, where you take your poop, like everything happens at home. And that's what they mean by a patient-centered medical home. Everything is important. Sonia put a note in there, one-stop shop. It's very much like a one-stop shop, but think about it in terms of primary care, right? It's your primary care one-stop shop. So it doesn't mean that you're going to see a neurologist there, but what it, look at who's dancing in complete care. It doesn't mean that you're going to see your neurologist there, but what it does mean is you're seeing a neurologist will be coordinated from there. So let's actually take a dive into these patient-centered medical homes, because this is a big model that really influenced change in this country. And while not all sites are still using the PCMH model, a lot of the structure of the medical homes are what you will find in healthcare transformation. So the definition of a medical home is a care model where patient treatment is coordinated through a primary care physician to ensure that people receive the necessary care when and where they need it and in a manner they can understand. So it basically was to keep you from going to the emergency room with all of your problems, going to those acute care centers where nothing gets tracked, everything just disappears into patient first, and to keep people from spending extra money by not going to the doctor. We wanted people to regularly be coming in. And the patient-centered medical home rests on some key concepts. First, comprehensive care, patient-centered care, coordinated care, accessible services that have high quality and safety. Now, this should sound familiar because those are the topics we just talked about that they were looking for when we talked about healthcare sector transformation. So the patient-centered medical home is one of the ways that they're taking all of those ideas and bringing them from theory into actual practice. Practice transformation, which you may have heard people talk about, this is what the AETCs are doing, refers to the process of change in the organization and the delivery of that care to advance improvement, patient-centered care, and to really bring about the characteristics of high-performing primary care. It was first and foremost a movement from volume to value. In the past, for those of you who've been in healthcare a while, you'll probably remember the days when we used to go to the doctor and we would get a list of tests, just like dozens of them. And it was often when people didn't know what was going on with us and they just ordered a shit ton of tests. Other times you would go see a doctor and maybe they didn't trust the tests that you had at the other doctor, even though it's the same blood draw at the same place with the same results. They wanted to do their own. Well, that's a real volume-based system where we pay people for every step in the system that they do. So if you deliver 10 tests, I pay you the money for doing 10 tests. But the trick is I pay you that money whether it was the right test or not. So you could have delivered 20 tests that had nothing to do with what was wrong with the patient and got reimbursed for it. So we started asking the question, isn't there a better way to pay people? That instead of paying you to do tests, maybe we should pay people for the outcome of those tests. So we'll pay you for the tests as long as they were the right tests that you did, and not just continually pay people to do a whole bunch of tests, because that was getting quite expensive. So we started setting our expectations as an outcome, which means everything that we were going to pay for was going to have to add value to the system in some way. So while it may be interesting to find out certain things, if at the end of the day it didn't improve care, we've decided the system should find a way to stop paying for that. Because we're not here to just pay for curious things. We're here to pay for things that we know resulted in value for the patient or client. When we look at this implementation of value-based care, this is really coming into focus around things like reimbursement. Right now, like we said, patients are often charged on a fee-for-service model, where they charge you for every service that was delivered. Only now you're actually seeing some changes in this model, where now people are being paid for value-based outcomes. So for example, in HIV care, can anybody tell me what is our outcome? And you can use the chat room or say out loud. What is the outcome of HIV care? If we were to say our value, what does that look like at the end of the equation? Say it again. What did you say, Travis? I can't hear you.
I apologize. Giving them the best care.
We can't hear you at all.
He said giving them the best care and for them to be adherent to their medication.
But how do we know? How do we measure that care?
Well, we do, keeping updates with them, making sure their viral load and everything is good where it should be.
Got it. Viral load suppression. That's the outcome, right?
Yes.
That's what we're looking for. At the end of all of our work, we want them to be suppressed, right? So a value-based model asks not how many medical visits did you have? How many viral loads did you do? The outcome-based model says, are your patients virally suppressed? If they're suppressed, we're going to pay you because we've gotten the outcome. If they're not suppressed, the question we have is why? And if you're not doing the things you should be doing, why are we paying you to keep doing them? Does that make sense to people? Does anyone have any questions about value-based care? Because this is a really big shift in the healthcare system. And it frames everything we do. Awesome. So I've got thumbs up for my complete care folks. I see Graziella, Sonia, yep, awesome. Okay, cool. So part of the reason we're doing this is also to look at shifting from reactive healthcare to proactive healthcare. So for example, right now, a lot of us are chasing lost to care people, right? We're out there running around trying to find people going, oh my God, you might be sick, let's find you. Or I don't know if you're sick, let's find you. We want to get in a place where we know our clients and patients aren't sick, and we know this because we're in the model of providing them preventative care. So I'm not chasing you to find a woman who hasn't had a cervical cancer screening. I'm calling you in advance to plan for this because I know you need one in 6 months, right? So right now, we're playing catch up, and we have to stop playing catch up and start playing forward thinking, which means I need to start looking at the patient roles and knowing who do I need to see so that I'm not chasing the people I've already missed, but I begin calling the people I need to see, not because they're sick, but because I'm keeping them from getting sick. Does that make sense? Yep. Awesome. So another thing that we did, and we've talked a lot about integration, and for those of you who are involved in the various projects that are happening at the state level, you're very probably entrenched in this, which is really integrating our services. New Jersey is in the process of integrating behavioral health. We're integrating capacity around trauma-informed care and trauma screening. We're integrating different doorways for housing and housing assessments, and the CHWs. That's like one of the biggest integration projects of all, right? Which is, how did we integrate community, right? Well, we integrated community by bringing the community into the clinic. And I think that these kinds of steps were all designed based on these models of transformation. Every time Loretta called me and said, what do we need to do here? I went back to the design of our system. What are we trying to do? How are we going to get there? And how will I know when we get there that it's better? Those are the questions I always ask myself when we sit down to do something different. The other thing that we've had to do, and this is probably something that you guys see more than anything. As you know, it is tradition in our medical systems for doctors to be in charge, for them to be very directive to the people around them, and to often listen, but not always have to incorporate what they hear from other people. That has changed a lot, and we've done something called flattening the hierarchy. This does not in any way usurp authority away from the prescriber. They are still the person who knows how to care for people in a medical sense. They are still the person who will prescribe the medication. They are still the person whose medical opinion is the single most important in that team. However, there are other opinions on the social life of that person, the supportive nature of that person's life, different lenses on them that are lenses the prescriber does not have. And in order to bring that into view and bring it into focus at the care team level, you have to make that equitable and you have to form a team. So now we're seeing more and more team-based environments. Sometimes they're physician-led, sometimes they're not. But as CHWs, you should feel confident that this system is being designed for you to have an equal voice on that care team. And if you're not being given an equal voice, then tomorrow during our quarterly meeting would be a really good time to bring that up during our feedback session, because we would love to hear that. Because sometimes this integration is very difficult, especially when it comes to things like integrating you into a hierarchical structure. The reason we flatten the hierarchy is because we want to build these teams, and teams are not built around a single leader like that. If you think about, when you think about your favorite teams in sports, often people don't like the team that has the one good player because they don't often win the championships. You might have the one person that impresses everybody, but rarely can a single person carry the whole team to the championship. Having more people there is better. You can have a brilliant star player on the team, but what's great is with a team, you could have 7 star players all playing together to really achieve some pretty phenomenal outcomes. But a team only works when everybody's working together. And it doesn't work when one person thinks that everybody else on the field is just their chess piece to move around however they like. It's really about how does the team come together and make decisions around how they do things collectively. We also, in the transformation, brought more of a hyper-focus on wellness. Right now, if you ask people, what does it mean to be healthy living with HIV? Our providers, well, let me ask you guys. At the end of the day, for those of us living with HIV, what defines healthy for you? When people ask you, are you healthy? What do you say?
Yes.
And what are your indicators of wellness? What makes you think you're healthy?
I'm adhering to my medicine with my medication, which would be my blood pressure. Oh, that.
You have to mute your computer.
Yeah. I'm adhering to my medication, blood pressure, ID meds. I exercise, eating healthy, all around able to do hobbies, work full time, and live life like nothing ever changed.
True. So are you regularly screened for colonoscopies?
I remind the doctor, yes, because
But
I had my
are
first
you,
one at the age
that happened
of
for
20.
you? How's your vitamin D?
I'm deficient.
Are you fixing that?
Yes, I do take vitamin D supplements.
Are you a smoker?
Trying to quit, but yes.
So when you look at that, as we started talking, you notice how you got more domains there, right? You started with, I take my meds, I'm virally suppressed, and then you're like, I have nutrition, and I do this, and I do that, right? Like, and that's right? Because that's wellness. It's all of those things. Right now, our clinics were focused on specific outcomes. If you walked into a primary care environment and you had the sniffles, if we fixed the sniffles, good job. That's what we were there to do. But what we didn't do was maybe prevent those sniffles by calling you and say, it's flu shot time and you should come in, right? That's predictive care. That's proactive. It's also looking at, if we have a clinic population that's 84% virally suppressed, everybody now is looking at the 16% that's not suppressed, going, okay, we got to get them healthy. But my question is, can I be virally suppressed and unhealthy?
Reason being, if you're not having your mental health treated, or
I'm virally suppressed. My blood pressure is through the roof. I've got clogged arteries. I'm not taking my Lipitor. I get no walking a day, and I'm considered grossly obese. There's probably stuff beyond my HIV that people might want to talk to me about, right? But that's not happening often in our HIV clinics. We're talking to people about their HIV disease, and yet they're not in primary care anywhere else. So if we're not attending to those things, then they don't have a focus of wellness in their life, because we're hyper-focused on suppression. And suppression is the beginning of wellness, I think. And that I will say that's my opinion, and not official medical things. That I think our journey to wellness begins the minute our chronic disease is being managed, and then we can talk about these other aspects of our life. So it really is this movement that we want from sick care to health care. And I really like this graphic. You can see at the bottom, sick care is pills, right? It's fixing things, like you've got problems. Healthcare is preventing those problems. It's helping you eat well so that you don't end up with a diabetes concern later in life. It's helping you change your habits so that if you're not getting exercise, we can work on that blood pressure, right? By getting you a little bit of 20 minutes a day out there. It's a different way to think about healthcare, and it's the way that this country needed to go, because we were becoming really unhealthy. And it's expensive to treat people who are unhealthy. But it's because our whole system was built only to look at people who were sick and not to look at people that were doing well. Any questions about that? Transformation, patient-centered medical home, anything there that folks want to talk about more? Awesome. Okay. So what I'm going to do now is we're going to drop in and just do a little bit more of a deep dive into the patient-centered medical home structures so that you'll see how some of this transformation played out. So one of the things they do in medical homes that really transform the way patient care takes place is called same-day appointment scheduling. This is also referred to as open access scheduling. Same-day appointment promotes continuity of care, and it helps people avoid unscheduled medical visits. That's what I love. They called it, emergency rooms are now called unscheduled care. Like I wasn't thinking about it. Because there are a lot of people who use emergency rooms for non-emergency things. It's not that they're in an emergency, they just don't have a doctor's appointment and they know they can go there and get one. Well, if my doctor would tell me that I could go there and get a same-day appointment for my sniffles, which I often can, that's twice as, well, I don't even know how many times cheaper it is to go to my primary care doc to have that seen versus taking it to an emergency room. When you end up with enhanced access, people are likely to come to their care team. They don't drop in elsewhere. So a couple things that are the benefits of this mechanism. One, it reduces unnecessary use of the ER, as we discussed. It decreases use of the retail clinics. These are our patient-first models. Like I said, those data, it's not that they provide bad care. I'm not commenting in any way or shading them. They provide a very good need, but they don't talk to our systems. We don't know that our patients went there unless the patients tell us. So people could be having symptoms of something that's related to their HIV care that we won't know about because we didn't see them and they went somewhere else. It provides greater continuity of care, and same-day appointment increases patient satisfaction. Imagine you call your doctor and say, I'm not feeling well, and they're like, oh my God, come in today, we'd love to take care of you. When's the last time you heard that? Right? So this same-day appointment scheduling, everybody says that's impossible. And yet I will tell you, every single site I have ever heard of and read about that has done this, it totally works. It doesn't sound like it should, but it absolutely works. You just have to structure your visits in the right way. And patient-centered medical homes do that. They hold blank visits every day so that when emergencies arise, because they do, they have a spot to put people. They also in medical homes do these things called daily briefings. A daily briefing is essentially a clinical team or care team meeting. And what they do is they review those patients or clients that they're supposed to see that day. It's part of a visit pre-planning process. Some people talk about it in a fancy way. They talk about the visit agenda, so that you can know what is going to happen that day with the patient. It's typically held daily, often in the morning or in the afternoon before a clinic session. So for example, if you have both a morning and an afternoon clinic, then they may have a briefing that occurs in the morning, let's say 8:30 before the 9 o'clock appointments begin, or they may have it at 12:30 before the 1 o'clock clinic starts. So depending on how your clinic is structured, you can actually have 2 briefings, but you always do it before a clinic session. During that session is when you identify gaps in care and you establish plans on what you're going to talk about during that visit. So that when you sit down, if 5 people need the patient to do something, everybody's got to talk about how this is going to happen, so that you don't walk in the door and have 7 people ask for 5 different things in 5 minutes, because that's overwhelming and people can't handle it, and that's how they forget to do things. And a daily briefing also gives the clinical team and the care team an opportunity to review any reports that may have come back from other visits. So if they've been to see a specialist, it gives you a chance to see that, so that you're not in the middle of the visit going, oh, hold on, let me see what happened. Oh, yeah, Mrs. Johnson, I'm sorry, you're going to die tomorrow, right? You should know that when you walk in the door, that you're going to have this conversation with somebody, so that you're in the place to have that conversation, so that you don't go, oh, that's bad, right? Because then we're watching you do that, right? So this helps remove all of that from the visit. It also lets you review labs and imaging reports, so that let's say you've been working really hard to get a patient virally suppressed, and that patient is suppressed, the first thing every care team member should do when they walk in that door is congratulate them. And you can identify that at the care team briefing, because you as the CHWs can say, did everybody say congratulations to her? Because this is a really big deal, and I want to make sure that we attend to this. You can do that in the daily briefing. And the benefit of this, excuse me, the benefit of this is you end up with more robust patient visits. If you know what's going to happen in that visit, and everybody's already planned out the order of the way it's going to occur, you go through the visit like that, because people know what to expect. You don't end up with curveballs, or worse, 5 people in the room at the same time all realizing the same thing and going, oh. Because then it makes you look like you don't know what's going on, because you don't know what's going on, right? So this is a way you fix that problem, by addressing the day's agenda before you go and visit with patients. Oh, one other thing. A daily briefing is also a really good time to say, hey, these 4 people have confirmed, these 2 have not. We may have a gap in the afternoon, just to let people know. Or, Mrs. Johnson's coming today, and everybody knows she's 45 minutes late. So she's got a 9 o'clock appointment. I'm going to move her to 9:45. We're going to start seeing people early and move them through today, so that no matter when she comes, we'll have some time to put her in. You can't do that unless you're meeting in the morning talking about that day, because you can't do it the day before, because people may call, they may cancel, you may find things out that morning. It's really important that you start your day this way inside medical homes. It helps organize the care, and that's part of the safety issue, right? That we all know what's going on. They also do this thing called population health management, and this is a lot to do with that health equity thing, which is looking at how do we identify groups of people who have similar needs and services and make sure that they're getting all the things they need. So for example, if we wanted to look at all of our people living with HIV, we would want the ability to make sure that our HIV patients are getting the expected outcome. Population health lets us do that. If you're inside an FQHC, this is your bread and butter. You are already doing this stuff. It is probably the way your data comes out of your system. If you are not an FQHC, this is a way that you look at segments of your population so that you don't drown in everybody's differing needs. So for example, if I were in a big program that wasn't just HIV specific, some population health groups that we may look at are people with diabetes. We know that's a difficult disease to manage. We know that there's a lot of needs. So we may look at all of the people with diabetes to make sure they're all getting the things they need. Then we'll say, all right, take the Etch-a-Sketch, shake it up. Now I want to see only the people with hypertension. So I'm going to look at those people and say, okay, are they getting all the outcomes they need? Then I'm going to shake up my Etch-a-Sketch and say, all right, what about my people who have more than 5 prescriptions? Are we adequately providing the care they need? So I ask my data, tell me everyone with more than 5 prescriptions, and then I make sure they're getting their outcomes. It's a way that you can look through your system to identify, is anybody falling through the cracks? And if they are, why? And that's a drill down process that some sites are already doing. It's a way that you fix the whole community of people. And also, the reason why most sites do this, it improves performance on measures. So for example, in an HIV clinic for a CHW, you might say, can you print me a report of every patient who needed to get an STI screening and didn't? Because then you can follow up on just those people who didn't get the STI screening. So if I've got 1,000 patients, I am not going to waste my time calling 800 people that have already done what it is I'm calling to do. Population health is about identifying only the 200 that need that phone call and calling them. So it saves time. It keeps your eyes focused where you need to be. When you look at population health management, these are the steps. First and foremost, you define the population. So when we think about HIV alone is a population that you could look at. But we look inside our population. So let's say we wanted to know specifically about the care for transgender patients in our system. So we define the population by saying we're looking at all patients of a trans-lived experience living with HIV who are in our clinic, right? So that's where we start, and we identify how many of those people. Then we say, okay, here are all of our, let's say we have 20 trans patients. Then we want to say, are all of these people getting everything they're supposed to? And this will help us identify the care gaps. So we might notice that maybe half the people aren't getting their cervical cancer screening. And we think that something's going on here. So you want to look at, number 3, stratify risks, mean I'm going to look at those 9 people that aren't getting that done and find out what is similar about them maybe. Because maybe what I've discovered is my 9 trans patients without a cervical cancer screening are my trans men who are uncomfortable coming into the practice because their gender presentation is masculine and people are treating them poorly because they're in a gynecology office and people perceive that they should look a certain way. So now I've identified something in my system, which is that trans men are uncomfortable because I've identified a care gap that is common for all of them. So then step 4, I would engage my providers and patients and I would say, okay, trans men, what is uncomfortable about this, or why are you not following through on this referral? But then I also ask the system, are you actually referring all of these people? Are they getting the information that they need? Are you explaining the importance of a cervical cancer screening to a trans man? And so then people go, okay, we move to step 5, we're going to change our system. So we're going to have a special trans clinic for trans men to have their cervical cancer screenings done the 3rd Thursday of the month, where we let the community know for everybody to come in. Then we measure our outcomes. At the end of that month, did more trans men get their cervical cancer screening done if they needed it? And then you circle back and do the whole loop again. Does that make sense? As a way you kind of move through a population to see where can we provide care, provide the care, did it work, and then you start the cycle again. You could do that with any of the groups of people you're helping. So if you notice that you think that all of the young gay and bisexual men under 25 are all kind of over here in a different space and you want to figure out why, take a look at just them. Ask your data people to give you the data to look at, see what's happening there. Because it's, sometimes we say, oh, they're not coming to care because it's stigma. But if we actually look at the data, they're coming to care and that it's not stigma, right? And so you always want to ask that question before you assume anything. And population health management in this 6-step process is a way you can do that. The other thing that we do in patient-centered medical homes that's a little different is this enhanced care plan development, which starts with, first of all, making sure every patient and client has a copy of their care plan and their treatment goals. We like to type these up in systems and turn them in and put them in records, but then patients don't know. I can tell you right now, I have no clue if I have a care plan or if I'm supposed to be doing something. I know I'm supposed to not smoke cigarettes, and I know I should not be doing drugs, and I know that I shouldn't drink a bottle of wine every night. But I don't know if that's a care plan or if that's just good advice, right? So I think when you look at this enhanced care plan development, it's meant to make sure that this thing we spend all this time on is actually actionable in my hands, that I can do something with it. So care plan development is also about providing education tools and resources so that with my care plan, I can do something with it. So if you tell me as a person who's pre-diabetic that I need to lower my glycemic intake and adjust my carbohydrates, what the hell does that mean, right? All I know is that I'm supposed to have cauliflower instead of potatoes, but is that enough, right? And so a lot of patients and clients have those questions. And so an enhanced care plan means that not only I have that care plan, but I can actually understand it and I can actually take action on it. It should track goals and progress at each visit. So whenever I'm in a meeting about medical case management and people say, oh, when do you do the care plan update? When do we do the care plan update, y'all? You can answer in the chat room. When does that happen? When do we say we do it, and when do we actually do it? And I'm going to eat my onion ring while you answer. So tell me, when do you update your care plans? All right, I'm going to call on you, complete care.
We do our pre-visit planning both the week before the next appointment, and then and then we talk about it on Fridays during huddle, the week prior to the next week's visits. And then if there was anything that was important, that was like a patient that has a barrier, we tried to address that throughout the week.
Yep, and then I see Sonia saying during an office visit or after an appointment has been verified. And then Graziella saying before and during. Yep. So here's the conundrum there. That means all of our updates have been built around system checkpoints of people coming in and doing stuff. If my care plan is me doing something in a week, then often that goes unchecked. Most systems, when I drop in and we do chart reviews, these care plans are updated every 6 months at the medical case management level generally, because that's when they see them and that's when they do their Ryan White recertification. Some care plans, some people have really good ones, and I don't want to give the impression that the whole system is bad at doing this. There are lots of people very good at making care plans, but what is missing is often that's not systematic. And it's not happening in everyone's environment. So we have to really look at, is the care plan being tracked and monitored by the system or by the patient needs? Because I think those are two different timelines, and we have to really take a look at that. Because, and this is why it's enhanced, you have to identify when a patient is hitting a barrier, and you have to address that. So if I'm supposed to be reducing my smoking, should not wait until the next visit to have that conversation. That should probably happen the next day or within a week. And so it's really making these care plans more effective in many ways by aligning the outcomes and the updates in the same place, so that we're not just updating plans when we see people, but we're updating plans when people have completed things or we're updating them because they've expressed they have a barrier and we're helping them get over it. We also do, in the patient-centered medical homes, and this is part of that care plan stuff, referral and test tracking. Right now, when you drop into environments and ask them how they track referrals, some places do this really well, and other places do this really not well. And depending on where you go, you'll find most people somewhere in the middle, likely. What we're looking for when we talk about referral and test tracking in patient-centered medical homes, they have to demonstrate and they have to show that they can do this, that they get results and reports in a timely manner, that they go out and come in a way that they can use them. They have to be able to demonstrate that all abnormal results are reviewed by clinicians, and they have to show that these results have been shared with patients. And the reason we do this is that, first of all, it's primarily safety, that we have made a referral, that it has been followed through on, and we know what happened. And lastly, it also prevents lost results, so that we don't have people pay for all this stuff in medicine that we never review. How many times did people go and get something and then the doctor never referred to it again? Right now, the example I have is I went for a DEXA scan because they wanted to do a baseline assessment on my bone density. I have no idea whatever happened to that, or whether my bones are okay or not, because I don't know if there's a really good system around closing that referral loop where I get my care. They made the referral, it was the appropriate referral, I got it done, I just don't know if we're using it in my care now. And I think this is what referral and test tracking was meant to fix, is make sure that if it was important enough for us to order, it should be important enough for us to have the result. And if we don't need the result, then why are we ordering it? And so referral and test tracking is meant to help figure that stuff out. We also in our medical homes have a huge focus on continuous quality improvement. We want to capture data that tracks performance in many places. First and foremost, patient satisfaction. And right now, most of this is measured in, did the receptionist treat you politely? Did the doctor call you back in a timely manner? It's very transactional. But we're also looking to expand this further down the road, which is, did the care you received support you in a good way? Did you understand what was said to you? And that's a lot of patient satisfaction, but we're also looking at skills too. But when we look at CQI, or in the Ryan White program, we call it CQM, clinical quality management, we're also looking at clinical measures like viral load suppression. We're also looking at our preventative measures, like have folks been vaccinated for the things we know they need, as well as different screening. But it's also, CQI is about having access to useful and accurate data to make improvements upon. For those of you, and I've worked in a lot of your old sites at this point through various projects, you've probably heard me say, don't fix a problem you don't have. Like it's a waste of time. And people do it all the time because they do their CQI, they do their quality management, but they don't do it based in data. They do it based in feelings. And we can feel all kinds of way about stuff, but it doesn't mean that it's true. And CQI is about having a system in place that makes sure that what you're doing is based on things that are real. So when we talk about the future, does that look possible to you all? Do you think we can do all of these things? I love it, Sony. That was the fastest yes ever. Yes! I can see you sitting at the desk with your enthusiasm. Yeah, so I mean, but the other question is, it looks pretty complicated, doesn't it? I mean, I got to admit, I spend all day in this stuff, and it is like pipes turning in 1,000 directions all at once. It's confusing.
It gets complicated.
Yeah, what are some ways, Brandy, because I know you've been in this a while, what are some ways you've seen you guys try to like make it not so complicated? What has been helpful?
Basically us working as a team, making sure that we're doing what we exactly have to do for those clients.
Yeah, you guys, like, there are a lot of communication about the changes inside when they happen. Talk to me about that.
like Travis said, on every Friday we have our huddles. So most likely we're sitting there talking about that person with all their chronic issues who does have the diabetes, hypertension, asthma, and stuff like that. We talk about them and make sure that they're getting the care that they're supposed to see, family practice, the eye doctor, their PAPs, their colonoscopies. So it's just a lot of talking and making sure that we all come together on it.
Yeah, a lot. And I think you've hit the nail on the head. And we talk about this when I go in and do coaching. A lot of this is solved with better communication.
Mm-hmm.
People have to learn to talk to each other better, whether that's desk to desk,
Mm-hmm.
agency to agency,
Mm-hmm.
county to county. All the lines of communication need to be better. And that's one of the biggest pieces of it. What about when they make a change? Do they write it down for you guys? Mm-hmm. And like say, here's the new protocol. Here's the new way we put this in the EHR.
Yeah. Or that we get our emails, our beautiful emails.
What about Sonia or Shelly or Graziella? How do you guys get information within your organizations about change? Email? Mm-hmm. Meetings? Yep. So a lot of folks, each organization will have their way of kind of how they push this stuff down and out to people. But as you make change, think about when you came in as CHWs. Did they do all of those things to prep the team for when you came? Probably not. So it's important to recognize that all the change we're making needs to have these kinds of supports behind it. So if you're recommending a change inside your organization, you want to do a flow a different way, you want to create a template, wink, wink, Travis, that is going to help with your services, you want to be able to have confidence that that is the right change to make, that those are the right questions to ask, and you need to be part of the quality process in order to do that and to support change. I see, Graziella, I keep open communication with the care team and meet in person or on the phone. Absolutely, totally. Live talking, whether that's distance or not, is always a good thing. It clears up any confusion that sometimes happens in an email. Oh, I hear Sonia, I ask a lot of questions. Absolutely. I am a question machine, because the more you know, the better you're going to be able to do. So again, I just want to sort of close out for today using this last quotation that actually came from the beginning, which was, it will not be easy for us to do this, but it will be most worthwhile. I think at the end of the day, we are the generation that gets to change healthcare. And that's going to happen whether we like it or not. And right now, you are in a system that is poised to be part of this change. And they want to hear from people like us more than anyone else. So it's important that you understand the mechanisms of change, why it's happening, so that you can adopt some of this language inside your system. So for example, you want to be able to ask things like, if they say, we're going to start doing this for patients, you should be the person going, how does this add value? How does this make their life better? Are we doing this because there's evidence behind it? Or are we just doing this because somebody wants to do this? Right? Are we asking this question because there's data that we're going to do something? Or did we just add a question for no reason? Right? These are the kinds of things that you need to understand, because if you're the CHW and you're the one bringing to the table the conversation about value, if you're the one bringing to the table the conversation around, hey, I'm not sure if this is efficient, or I'm not sure if this is patient-centered, that's your widget. You're supposed to ask those questions. You're supposed to be the one that brings that to the table. But you got to speak their language so they know what you're saying. Any questions? Make sense? I'm seeing our video folks are saying yes. So what we're going to do, I'm just going to give you guys just a highlight here. What we're going to do on our next webinar is we're going to talk about things like the rise of teens, and we're going to talk a little bit more about nuts and bolts mechanics of how these teams do their everyday work. So we're going to take that morning briefing and we're going to crack it open, and I'm going to show you all the pieces of it so that you see how they prep for it, what they're supposed to do with it, and then how they close a visit afterwards with it. So that'll be our whole focus of our next webinar. What we will do now after this, I will go ahead and by the end of the week, we'll send out the behavioral health self-study models for the Access program. At the end of each of those, there is a test. You need to take the test. It's basically our demonstration that shows that you actually did the module. Once you've done that, send me the results of your behavioral module test. I will send those up to Columbia University. They will issue the certificates from those completion of those modules, and then we'll schedule your clinical rotation. Sound good? Awesome. And will we be seeing everyone tomorrow for the quarterly meeting?
Yes.
I will not be there. I'm sorry.
Awesome. So make sure you guys get there. We've got a lot of great stuff planned for you. And thank you guys for taking out the time today. We really appreciate it. We know that this is a lot to get you out of your organizations for capacity. So thank you to your bosses. Thank you to you. And we'll see you guys tomorrow.